All right. Welcome everyone to our IHI presentation tonight. My name is Dr. Hankerson. I am one of the DNP clinical faculty and Frontier's IHI Open School Chapter faculty lead.
Yeah.
I'd like to welcome everyone and thank everyone for attending our presentation tonight. For those of you who are attending for course recommendation, don't forget to follow the per the course. I would like to introduce you to our speaker. Dr. Cochran is a certified nurse midwife and women's health nurse practitioner from Frontier. She also earned a Bachelor's of Science in Nursing and a PhD from the University of Virginia and a Master's of Science in Nursing from Case Western Reserve University. She has taught undergrad and graduate students for 19 years. At Frontier, she's also served as course coordinator, clinical bound team leader, associate dean of midwifery and women's health, and also associate dean of academic affairs. She holds certifications in online teaching from the Online Learning Consortium and a certified nurse educator by the National League of Nursing. Her scholarly focus has primarily been nursing history, having been fortunate to receive outstanding mentoring during her PhD dissertation process and in the years since. She has researched and written about the history of Frontier Nursing Service, the Catholic Maternity Institute, and other nursing history topics. She's also published papers and book chapters about clinical prenatal care and gynecological topics. Dr. Cochran, you could take it away.
Thank you so much, Dr. Hankerson. I appreciate that introduction. Good evening, everyone, and thank you for being here with me as we explore the connections between clinical practice and quality improvement measures you're currently using and historical data-related activities of the Frontier Nursing Service. And I really hope that the next hour is going to be fun and eye-opening. I'm so looking forward to hearing from you throughout the session about your experiences with establishing measures and collecting and analyzing data in your quality improvement. Now, this session's focus is a little bit different than other IHI sessions, I bet, and you might be wondering why I wanted to spend time on this topic. Well, as a nurse historian, I've researched the Frontier Nursing Service and other nursing and midwifery services for almost 20 years. It's long been really fascinating to me to identify lessons from history that can help us provide effective and equitable care for today's patients. One of the most compelling aspects of historical research methods for me is that excellent historical research requires us to purposely consider many contextual factors that affect the people and places we study. For example, social and cultural factors, economic pressures, geographic and transportation challenges. And that feels completely aligned with how I've tried to care for patients as a nurse midwife and nurse practitioner. And I bet it's the same for you. So I just wanted to highlight that connection between historical exploration and providing care today. So here is the general plan for our time together this evening. As a jumping off point, I'd like to use a paper that I co-wrote with my brilliant colleague, mentor, and friend, Dr. Janet Engstrom. Many of you know Dr. Engstrom from the Epi and Biostats course. We published a paper a couple of years ago in the Register of the Kentucky Historical Society, and it was called See One, Do One, Teach One, and Record Your Results Accurately, How and Why the Frontier Nursing Service Told Its Story with Data. So I want to share some of the findings from our paper, but as we go along, I'm going to ask you all to help make the connections explicit between FNS historical use of data and
I
today's
just want to
clinical
ask
practice
everybody
and
to
quality
stay
improvement work.
muted while Dr. Cochran is speaking. If you can mute your microphone, we are a wonderfully big group. Thank you all.
Thanks so much. So I'm going to provide some ideas as we go along, and then I'll invite you to share. And so please jump in and provide examples and ideas so we can all learn from each other. So as an educator, you know, I always have to think about learning objectives. So what do I hope that you'll take from this session? If we do what I hope to do over the next hour, you'll have an enhanced understanding of the types and purposes of data collection that the FNS nurses participated in during the first half of the 20th century. You'll also be able to identify the barriers that those nurses overcame for their data collection, as well as hear from participants in the group about barriers that we have to overcome for data collection today. And then thinking about historical FNS examples, as well as examples from today, you'll also have a deeper understanding of the ways that data collection and analysis are not neutral or completely objective. The data collected and analyzed are always informed by decisions that are biased to some degree. I hope you'll have a renewed commitment to ensuring the robust involvement of stakeholders in all decisions about data collection and analysis, even if we as experts are sure we've ruled out bias or we think stakeholders don't have enough expertise. And of course, stakeholders are more than healthcare providers. They include patients, families, communities, and funders such as insurance companies, government, and private donors. So I know everyone here is committed to equitable, unbiased care of patients and to making sound decisions to reduce bias through the quality improvement, project planning, and implementation processes. Here, I think historical exploration can be helpful.
Okay, I have to go do my class.
Because sometimes it's more apparent where bias creeps into data decisions when we examine a long ago historical example. By the end of our session, I hope you'll see that FNS nurses and leaders were disruptive innovators and in some ways informed by unexamined privilege and class biases that affected their data collection and analysis activities. As we honor the work they did, we'll also complicate the straightforward and heroic historical narrative that's been a major emphasis of FNS history to date. So one last quick bit of housekeeping before we dive into the topic at hand. I want to spend just a quick moment clarifying what we mean by data and how that relates to the IHI term measures. In our paper, Dr. Engstrom and I used overlapping conceptualizations of data, including data about populations, individual patients and economics, record systems, documentation of clinical care, outcomes, and research. And of course, these data elements are not synonymous, but they relate to each other in important ways. And as you know, the IHI model for improvement includes establishing measures, which include both quantitative and qualitative data that function as feedback. So the clinical care team can determine if a change in practice is needed and whether any change results in improved outcomes. And of course, IHI emphasizes that stakeholders must contribute to identifying measures that reflect improvement from their perspectives. So next up, for anybody who might not be familiar with the specifics of the Frontier Nursing Service story, I'll start with a quick overview. Now, many of you, but maybe not all of you, know that the FNS was the healthcare organization begun in 1925, and the school, which eventually became Frontier Nursing University, started in 1939 as one of the FNS's many activities. From its inception in 1925, the purpose of the Frontier Nursing Service was to safeguard the lives and health of mothers and young children by providing trained nurse midwives for rural areas where there are no resident physicians. To carry out that goal, FNS nurses cared for a patient population of more than 10,000 people in one of the most remote, rugged, and impoverished areas in southeastern Kentucky. The work included maternity care, as well as comprehensive public health programs focused on sanitation, vaccination, health education, and other preventative services, and caring for people with illnesses and injuries. Now, infrastructure such as electricity, plumbing, and sanitation were minimal or non-existent. The nurses traveled almost exclusively by horseback on mountain trails, particularly during the service's first quarter century, and transported patients through the forest on hand-carried makeshift stretchers or in flat-bottom boats. The physical arrangement of the service's facilities and people enhanced the nurses' ability to manage the volume of patient care in that challenging environment. The FNS used a decentralized organization similar to that of the Scottish Highlands and Islands Medical and Nursing Service, with districts arrayed like spokes of a wheel around the service headquarters and hospital. And on the slide, you'll see the headquarters and hospital in the red boxes and the district centers in blue. 1 or 2 nurses staffed each district nursing center, positioned at the center of each district. Nurses covered an area of about 80 square miles, but because of the arrangement, they were only 5 miles or about an hour's horseback ride away from each patient. The nurses often managed complications beyond their scope of practice because physicians were either unwilling to live in the area or were unable to arrive at a patient's bedside in time to make a difference. Despite the complexity of patients' health problems, FNS Care prioritized a low technology approach to medicine and nursing, bringing only the elements they thought to be crucial in modern medicine, such as immunizations, prenatal care, and the use of sterile technique for births. Most FNS patients delivered their babies at home rather than in the hospital prior to the 1950s. Now, because of the area's cash-poor economy, patients often were unable to pay the small fee that the service charged, and the FNS consistently operated with a meager budget that relied heavily on private donations. FNS founder Mary Breckinridge chose Southeastern Kentucky for the Frontier Nursing Service rather than another area of the country for several reasons. She envisioned the service would fill an important need as people in that remote area lacked access to what was considered professional health care. Breckinridge's extensive family network in Kentucky also provided crucial connections and credibility with some important decision makers at the local and state levels. Additionally, the extreme geography and climate supported her argument for eventual replication of the service. Breckinridge said, if the work I had in mind could be done there, it could be duplicated anywhere in the United States with less effort. Now that we're hopefully all on the same page about the basics of the Frontier Nursing Services story, let's begin to focus on FNS's nurses' data activities. So I'm going to invite you to type in the chat box or unmute and use your microphone to share your thoughts about this question. Knowing what you know about FNS history, what types of data do you think FNS nurses and leaders in the first half of the 20th century were interested in collecting and analyzing? So what kinds of nursing activities or patient characteristics do you think that they wanted to record, measure, and analyze? So type in or unmute. Love to hear from you.
Hi.
Yeah, go
So
right ahead.
hi, Nikhat. So I think they wanted to see the mortality rate, like, how soon they got medical services and the mortality rate.
Yes, excellent. Really, really good point. Yes, and I'm seeing lots of comments in the chat right along those lines. Births, deaths, outcomes, rates of infection. I like that. That's another good one. Laceration types, mental health, annual deliveries, family structure. Yeah, great ideas. Let's see if I missed any. Ability to access healthcare. I like that. You all have great ideas. I'm just reading through all these great comments. Oh, contaminants in or around the living space, distance to nearest healthcare services. Yes, for sure. Number of children, known or potential miscarriages. Yep, common medications, prenatal care usage. Yeah, nutrition. Fantastic ideas. Just give you another couple of minutes to see anything else you want to come up with. Access to care. Yes. Yeah, birth control for sure in the later years. Yes. Resources, weather conditions, yeah, and the effects it would have. Access to natural resources like water sources. Yes, we're definitely going to cover that in just a second. Yeah. Oh, and I like that decreased infant maternal mortality rates. So if their care was having any effect. Yeah, great ideas, everyone. Excellent, great ideas. Super. Thank you for sharing those. That was exactly, you're totally on the right track. So I'd like to build on what you all have offered and maybe provide even just a bit more detail with some of the findings from our register paper. So I found it helpful as I think about data types to think about the purposes of data collection for early FNS nurses, because those purposes drove the types of data collected. So I'll kind of talk about that first, because data collection was burdensome for the nurses. And I suspect if I did a show of hands from everybody who, whether you feel like data collection can be burdensome for us today, I bet you'd say yes. So why did the FNS nurses spend precious time and energy on collecting data? Well, broadly speaking, the FNS focus on documentation aligned with the contemporary principles of maternal, infant, and public health in the early 20th century that focused on documenting health outcomes. FNS leadership also recognized the need for quantifiable outcomes to make a strong case that nurse midwives were safe and effective maternity care providers, and that the service should be replicated in other parts of the country to meet the needs of other communities in rural and underserved areas. FNS leaders also knew that they needed data to convince wealthy donors that the service was using their donations responsibly and that their donations were having a significant impact. So now I'll quickly share some of the types of data collection activities that Dr. Engstrom and I included in our register paper. Around the time the service was launched, a team surveyed the area to establish the size of the population and to gather baseline birth and mortality rates. And a lot of this is echoing exactly what you all typed in. It turned out to be really helpful because the survey identified 10% more births and 17% more deaths than had been registered previously. FNS leaders used this information to align with the claim that death rates for mothers and babies were higher in that region than national rates. Together, these analyses supported Breckenridge's arguments that the area would benefit from professional health care and provided a foundation for a future argument for replication elsewhere. Now, for decades, FNS nurses and leaders continued with their focus on aggregating counts of perinatal outcomes like stillbirths, infant deaths, and maternal illnesses and deaths. They reported and widely published these counts in groups of 1,000 and then in 10,000 midwifery cases. And you can see on the slide a report of the third 1,000th confinements. So I want to focus now on a crucially important aspect of the FNS approach to data and really showed the types of data. And this was what was called the record routine. Now, the first edition of the record routine was published in 1930 and provided all members of FNS staff with extensive and highly detailed guidelines for data collection. The level of detail in the record routine left little to the interpretation of individual nurses and standardized the nurses' data collection activities. Operational definitions of dozens of data points and instructions for recording data filled 22 pages in the first edition of the record routine and increased to 54 pages by the third edition. Nurses were thus able to record information during and after patient care encounters in a highly uniform manner. And on this slide, you're not going to be able to read this, in detail, but you'll see a couple of examples of data documentation, and you can just see how detailed that is. FNS leaders communicated to stakeholders that the service was paying studious attention to quality by saying, "We in the Frontier Nursing Service have an immense respect for facts. Our statistics are carefully compiled, checked, and rechecked." And in fact, Mary Breckinridge was so focused on accuracy that she modified the medical education adage that I think we've all heard, see one, do one, teach one. She modified it by saying to staff, see one, do one, teach one, and record your results accurately. Some interesting and perhaps maybe not completely expected examples of data the nurses collected include documentation of patients' water supply, although somebody did type that in a moment ago. And of course, this helped the nurses to track outbreaks of waterborne illnesses. And another example is construction of patients' homes, given potential effects on insect-borne illnesses, for example. And here on this slide, you can see some details of the definitions of home construction. And these definitions warranted 2 pages of lots of details. FNS nurses and leaders also recognize the need for quantifiable outcomes to convince wealthy donors that the service was using their donations responsibly. They did this in part by recording and analyzing the volume of patient care activities carried out by a limited number of staff members. Data points included patient visits at nursing centers and in homes, births, perinatal complications the nurses managed, vaccinations the nurses administered, types of illnesses and injuries they treated, time spent on each activity, and patient payments requested and received. Now, as one illustrative example, in 1945, FNS staff published a summary of the first 20 years of the organization, documenting that the nurses provided care to 27,397 patients, and this included more than 17,000 children, attended 5,963 births, and administered 136,604 vaccinations. That is pretty impressive in my mind. So now that we've talked about some of the purposes and types of data the FNS nurses collected and analyzed, let's think about how challenging that might have been for them. So here is another question that I would like to put out to the group and see what kinds of great things you come up with. Knowing what you know about FNS history, what do you think were the major barriers and challenges the FNS nurses and leaders faced in data collection and analysis? What do you think? What kinds of things did they have to overcome? Oh, I like that trust of patients. Yeah, geographic, physical barriers. Yeah, lots of logistical things. Access to patients, trust of lots of folks in the community, distance. Yeah, weather, lack of funds. Oh, safekeeping of data. That's a great idea. Weather, paper documentation that was could get wet or lost. Supplies, time restraints. Burnout. Yeah. Having to carry all the supplies and everything. Educational gaps, transportation. Lots of you have commented about patient trust, and I really appreciate that. Buy-in from stakeholders, yeah. Oh, and that's a great idea. Lack of training and data analysis by the nurses. Yeah. And not enough nurses. And boy, I bet you, as you all are reading through these, you're thinking that many of them apply to today as well, right? Yeah, do it. Sounds like my job as a home birth midwife. Yes, absolutely. Staff shortages. Yes. You all are right on the right track. Were there other priorities, do you think, that might have been competing with data collection activities? What kinds of things can you think of along those lines? Yeah, workload, illness. Yeah, lots of patient care. Yeah. Yes. I bet you all can think about your jobs right now and think of a lot of these. Yeah. Burnout. Several of you have talked about burnout. Yeah, they had a very extensive system of the nurses taking vacations and having coverage in their districts. So there was a big sort of embracing of the idea that folks needed to have time away to regroup. Extra time to document. You got it. Great ideas, everyone. All right. So again, I'll add to what you all have shared and provide just a bit more detail about everything. FNS leaders overcame barriers and devoted limited resources to the difficult tasks of establishing and maintaining comprehensive data collection systems. And one example that I think really vividly illustrates the challenges of data collection was the 1925 baseline survey I mentioned. That small survey team, led by a Scottish researcher, carried out an extensive survey of almost 2,000 families in the area over about a 2-month period. The team covered nearly 400 square miles of rugged territory to establish the size of the population and the baseline birth and mortality rates prior to the FNS beginning their work. And logistical challenges abounded, including incredibly rugged terrain. Now, some of you who traveled to Hayden for Frontier Bound or Clinical Bound in years past, before we moved to the Versailles campus, likely have an idea of what I mean by that. And at that time in 1925, unlike when you went to Frontier Bound, if you did, transportation was limited to horse or muleback riding. The survey team leader described some of the challenges faced by saying, "In my first week, there was a tide due to flooding that confined me on a small island for 4 days. Later, owing to a shortage of oats, my horse was given a green feed, which, together with his being out in a severe hailstorm the same day, gave him colic so badly that he couldn't be ridden for 2 days." Now, additionally, is anybody else having sound difficulty, or is it just Christina? Okay, great. Okay, well, I hope that gets straightened out for you, Christina. I just want to make sure it wasn't me. Okay, so additionally, the team often could not locate blacksmiths to shoe horses. A drought made safe drinking water impossible to find, and snakes were underfoot frequently. Other difficulties stemmed from the cultural chasm between the educated middle and upper class nurses and impoverished community members whose priorities differed from theirs. Mary Breckenridge lamented that it was not easy to gather data covering a number of years in a country where calendars and diaries and marriage lines and birth certificates and even clocks were so uncommon as to be of little help in marking the passage of time. And as to the burial permits, there were none. Even after this initial survey, throughout the history of the FNS, nurses struggled to comply with data collection requirements. Documentation tasks were relentless and burdensome on top of clinical duties. And many of you typed in about relating to that, and probably you have in mind having to stay after clinic or your call shift to finish documentation tasks. Now, some other challenges that you might never have had to deal with, but FNS nurses did, were electricity that was unavailable or unreliable, freezing or scorching temperatures without shelter or climate control, droughts, floods, rain, snowstorms, skittish horses, snakes, and steep mountain trails. Now, relentless patient care requirements included busy clinic days, large numbers of home visits, as well as being on call for labors and births, often all on the same day. And you can imagine how exhausting these were for FNS nurses. So now I'd like to invite you to think about some of the barriers that you found, depending on where you are in your quality improvement project process, or anticipate finding in data collection and analysis for your quality improvement work. What are the barriers that you have faced or are facing or anticipate facing? So other staff seeing importance. Yeah, some buy-in. Yeah, time. Resistance, lots of time. Yep. Lack of education, pushback from staff. Yeah. Got it. Boy, I hope it's really validating as you all are reading this to know that many people are experiencing some of the same things. Ambiguous charting, that's good. Staff buy-in like physicians. Short visit schedule. These are great ideas, and many of them have overlap with the FNS nurses. Burnout, message overload, yeah. Staff resistance to change, yeah. Inability to make permanent change as a student. I bet lots of you are feeling that. A need for an increase in visit time. Forms not completed when I'm not in clinic. I see. Great ideas, everyone. I really appreciate hearing from all of you. I see so many comments about other members of the team, other stakeholders, and the buy-in. So important. I know your faculty spend an awful lot of time coaching you through how to work through that. Lack of interpreter services, that's a good one. Excellent. Right, great ideas, everyone. Thank you for sharing those. I'm seeing a lot of inaccurate or incomplete documentation, not documenting teaching, so things being done maybe, but not documented, which makes it hard if you're not capturing the data, right? Yeah. Super ideas, everyone. Now, I'd like to transition next to another topic, and that is bias and privilege that influence the FNS's data activities. FNS staff presented data collection and analysis activities as objective assessments and in a positive light, and many historical analyses have portrayed FNS data in the same way. But in our register paper, we argue that privilege and bias directly informed these processes. And I'll share some of the ideas we include in our paper, and then we'll turn our attention to making connections with bias and privilege that can influence quality improvement activities today. As we consider some of the data-related decisions that FNS leaders made in the first half of the 20th century through our 21st century eyes, we see instances of bias and privilege, particularly class-based privilege. One example is a survey that Mary Breckenridge carried out in 1923. So that was 2 years before the start of the Frontier Nursing Service. And in this survey, she obtained information about the community midwives, so the midwives who were living and working in the community before the FNS began. Now, with the survey, she began with the premise that professionals from outside the mountains should replace the local midwives who had previously provided nearly all of the care to birthing women. This survey and its beginning premise provide a vivid example of unexamined privilege influencing data collection before it's even begun. So here's what happened in case you're not familiar with this. In 1923, Breckenridge met and obtained information about 53 midwives. She collected demographic and personal data, including the local midwives' age, race, literacy, and what she called native intelligence, marital status, husband's occupations and literacy status, number of biological children, home construction, number of years in practice, obstetrical knowledge, cleanliness, preparation as a birth attendant, and birth practices each midwife employed. On this slide, you're not going to be able to read unless you have a very big screen. You're not going to be able to read the details, but you'll get an idea that this is a published table of the findings about each of the 53 midwives. Breckenridge's assessment of the local midwives was not favorable. None of the midwives had formal training, and any preparation in midwifery had come from what she called other midwives. 12 of the 53 midwives could read and write. None provided prenatal or postnatal care or owned any of the equipment that contemporary standards required. Breckenridge deemed many of the midwives to be what she called unclean, with 27 of the 53 being what she called fair and 10 being what she called dirty. Most used folk remedies and invasive, non-sterile procedures. Few of the midwives ever called for a doctor to assist with complications. Breckenridge's class and privilege shaped her analyses of the midwifery survey. Her assessment of the local midwives' training did not acknowledge most of the women lacked access to higher education or professional training by virtue of their geographic and economic situations. She did not acknowledge that the local midwives might have resented an outsider's, quote, investigation of them. Breckenridge reported local midwives' inadequate data collection and documentation of midwifery care by saying, except only in the vaguest way, none of the midwives had any idea of how many mothers they had delivered before birth registration began. Now, Breckenridge clearly valued detailed records and analysis. However, she did not acknowledge that the expectation and ability to document midwifery care was one rooted in middle-class values and, more importantly, dependent on resources the local midwives likely did not possess. Likewise, when Breckenridge queried the midwives about when they send for a doctor, the midwives responded with a protest against the very idea. Now, Breckenridge attributed the midwives' decisions about physician collaboration to a lack of obstetrical knowledge or to an unwillingness to work alongside a physician, rather than to a lack of social and professional connections that Breckenridge and the FNS enjoyed. Breckenridge's assessment of the midwife's age reflected class biases. She said, the native midwife does not begin to practice until she is over 40 and has raised her family. And by saying that, she didn't acknowledge that most mountain women had too many responsibilities with their own families, and without domestic help that was beyond their means, could not pursue careers before their children were grown. So I'll quickly mention one more example of bias infusing data collection activities. Now, this one is even a bit more challenging to think about because it's rooted in eugenics-informed ideas. In some ways, this one feels much more extreme and anachronistic, something that we wouldn't fall prey to today. But I would argue that people can have lots of ideas work their way into their worldviews and don't always recognize the harm at the time. And so that's why I'm sharing this. So again, here's what happened. Informed by intelligence testing of children that she was involved with in her work in post-World War I France, Mary Breckenridge arranged for an expert in intelligence assessments in children to conduct mental and intelligence tests of a group of 66 children in the proposed service area just before the FNS opened. The researcher concluded that the native capacity is average, but the environment does not stimulate that ability sufficiently to bring it to its best possible maturity. So FNS staff used the results to argue that mountain people were what they called fine stock, and the abysmal population health indicators were due to isolation and poor access to health care rather than to inherent weakness in the people. This allowed FNS leaders to make the case that Eastern Kentucky was a wise location for the service and supported fundraising pleas with donors. So even though the measures for children's intelligence supported FNS data collection priorities and appeared objective on the surface, they were rooted in biased systems and structures and were demonstrably unrelated to the FNS's true mission of improving the health of community members. So speaking of objectivity, I'd like to make quick mention of a body of literature that Dr. Engstrom and I cite in our paper. A large body of scholarship explores the meanings of quantification and data. Data science scholars, historians, anthropologists, and others caution against unexamined acceptance that quantification is uniformly positive. Some scholars argue that arriving at truth through quantitative methods assumes objectivity that might not be present or possible. So thinking again about the FNS stories I just shared, those examples of bias and privilege aren't easy or comfortable to consider, are they? But my hope is that by turning our attention to these long ago examples, we can begin to think about ways that our data activities are affected by bias and privilege today. So let's consider a few questions now to make these links. So here's something that I'd like you to ponder. How can bias or privilege affect the measures, including instruments, that today's clinicians might choose for quality improvement? What kinds of things can you think of? Important to ask these hard questions. Yes. Reading and writing literacy, language barriers that aren't considered. Yeah, absolutely. Yeah, access to technology, cultural considerations, lots of these things that if we're not careful, we can just really overlook them. Trust issues. Oh, that's a really good point. The assumption that certain demographics won't understand. These are great ideas. Super ideas, everyone. Yeah, and maybe a theme that's running through a lot of what I'm seeing are, bias and privilege that is sort of entrenched in the healthcare system. And many of you are very experienced nurses and clinicians. And, when we get to that point, we've often been entrenched in a system so long that we often don't notice possible bias and privilege. Dr. Schaefer says, never asking for feedback from the clients on the tools themselves. That is excellent. Yeah. Literature resources may have bias. Yes. There are lots of examples of things that are published, and therefore we can sometimes just take them right off the shelf and say, well, it must be fine. It was published in a peer-reviewed journal or whatever. And there can be bias baked right in. Yeah. And a number of you have mentioned stigma, and something that comes to my mind with stigma is that, when we're studying, gathering data about stigmatized healthcare conditions, it can be easy for us as clinicians to kind of lose sight of the difficulties patients can face discussing it and addressing it. Lots of research don't look at physiologic processes, assume pathology. Yeah, that's a great idea. Super ideas. Now, I have another sort of broader question to think about. Are there other ways that you've seen bias or privilege affect the selection and analysis of QI measures? So anything else that you haven't thought of that you want to bring up where you've spotted bias or privilege? Anybody thought about bias or baked into professional organization national guidelines? Anybody spotted anything along those lines? Everyone. Many of us going into the process an idea of what we want to implement rather than figure out what our patients need us to implement. Yeah. Great ideas. And I bet your faculty in your project courses are helping you think along these lines. Yeah, bias affecting funding. Yeah, great ideas. So Kate had a comment about guidelines about, for example, physical activity hard to follow for those who don't have time or money. So that is something that I think is so important that we can come up with guidelines and collect data about certain issues without thinking of the social determinants of health that really affect that. And I think sometimes patients can kind of leave with the idea that they have failed if they're not, following the guidelines. Oh, and Julie, assuming all patients have the same access to care. Excellent. Access becomes more of an issue the farther out you go from the road system. Yeah, so thinking right back to the FNS example. Yeah. Super ideas, everyone. Cost of living, getting to appointments. Yeah. And it can be really easy for us to have our focus of our whatever we're studying, whatever we're gathering data about, and sort of block out some of these other contextual factors. And I mentioned at the very beginning of this, talking about why I love historical research so much, because you have to consider the context. Oh, and Dr. Schaefer, I agree. Getting misty reading all the smart healthcare leaders' comments. Love it. Yeah. Great ideas, everyone. I'm just thrilled to read all of this. Well, I am keeping my eye on the time, and we are not too far from needing to wrap up. And so what I'd like to do is move toward wrapping up. And what I'm most interested in as concluding our session is to hear from you about your conclusions and takeaway points. So I'd like to focus on that as our wrap up. So I'd like to ask you if you learned anything new or surprising about early FNS nurses, data collection and analysis. Anybody have anything that was new to them, surprising to them, interesting to them about the FNS nurses' data activities?
I think it was just interesting to hear that the burden of data collection goes, and I use burden with love and the knowledge that we need to do it, but the burden of data collection is so historical.
Yes, absolutely, Kiki. Yes.
That's really both reassuring and sad all at the same time.
Right. Yeah, we're at a century mark now, right, of having the same issues. Yeah. Thanks for bringing that up.
Hello.
Yes, go right ahead.
Yeah, watching the video, seeing the brave ladies on the horses back, getting waters and in a bag, the snow, and going to collect important data that needed for the patients, to see how things change because of their hard work today. It's it's very thrilling, and It's very touching, heart touching, to tell you the truth. Yeah.
Thank you for sharing that. I'm glad that had some things that really grabbed your attention. I'm seeing lots of other great comments in the chat.
Hello.
Yes, go right ahead.
Yeah, seeing the midwives transport the patients on the stretchers reminded me of when I was growing up in my village, where the hospital was about 3 to 4 hours walk. So if somebody fell sick and they needed to take her to the hospital, they will hand make stretchers and transport the patient on there. They have like 6 men, 2 at the bottom, 2 in the middle, and 2 in the front. They'll carry the person overhead to the hospital.
And would
So I
walk
thought
for
that was,
miles.
yeah, for about 4 hours walk.
Oh my goodness.
And looking at those pictures just reminded me of that time. And I remember I was in elementary school, I think maybe 3rd grade, and my sister had gotten married and was pregnant and went into labor, but was unable to deliver. So they had to do that. They have to transport her like that to the hospital. Unfortunately, by the time they got there, the baby had died in her.
Oh my goodness.
Yeah.
Wow.
So that brought me some interesting and some painful memory. But you know, seeing that was also happening in developed countries kind of just solidify that we are developing as a as a people, no matter what area you come from.
Gosh, I'm so sorry about that in your family, and I really appreciate you sharing that story.
Thank you.
I see lots of really important and insightful comments, lots of comments about it being sort of a mixed bag, lots of kind of heroic and exciting kinds of things, and then some difficult things to ponder.
And I want to add, we've come a long way in healthcare, but we have to, even though, we feel like we have it easier than the women on the horseback did, we still have to continue to be heroes. We still have to continue to collect all this, and hopefully in 100 years, they'll look at us the same way.
Right. Thank you for that. Really important point.
I wanted to just say how I really appreciated this presentation and the work you've done, Dr. Cockrum, because I think it is important to, while we have to acknowledge like the positive things that our profession has brought, we also have to like look at the ways in which we didn't do things right, and um, and hopefully that informs doing things better going forward. So I really appreciate the openness and transparency and just showing that it wasn't all just heroes on horsebacks.
Yes, thank you for that. I appreciate that comment very much. I have one other question I'd like you all to think about, whether you have any new or refined ideas about minimizing the effects of bias and privilege in your quality improvement work. What kinds of things might you take forward into your project, depending on where you are in your project process? More opportunity for patient feedback. I love that.
Yeah, and also embracing the patient's culture, because for instance, a Spanish lady might come in and with their husbands, and they're looking up to the husband to, make decisions about their care and stuff like that. And you might be looking like, okay, why are you not doing it yourself? but it's cultural. So being open to that, to accepting those kind of situations will help the patient feel free or more open to, talking about their health or listening to what the providers are saying, as opposed to, oh, you have to do it yourself.
Something I really appreciate about what you said was the importance of focusing on that person to see what is important to them and whether it is, aligned with what we know of a certain demographic or, anything else, but really paying attention to that person, getting feedback from that person. And that seems to be a common theme of comments that I'm seeing. Curiosity, I love that. Acknowledging the overwhelm that providers can feel hearing a patient's story, prioritizing that over survey results. What a really nice comment. Collaboration with colleagues.
I have found in my patient surveys, I knew coming into this that we weren't meeting guidelines and the standard of care. And in my patient surveys, I'm realizing that the patients aren't experiencing that. They think that our care is exceptional. And so how do we continue to grow in our care while also knowing that the care that the patients perceive is, all fives across the board on the survey. I'm finding really hard to find gaps.
Interesting. I bet your project faculty will be able to guide you very well with that. I have great faith in my faculty colleagues.
I had a similar experience, is that the patient population is so marginalized and the disparity is so pronounced across the board, not just with primary care, that they were so thankful that someone saw them, not let alone ask them their experience and were engaged in improving their outcomes, but that they were seen. And so it was almost a bias from the beginning, a positive skew bias, because they were actually being seen, which was pretty sad, but also heartening at the end that we can make a difference in that little spot too.
Goodness, amazing work that you all are doing. It is so impressive. I have not taught in the DMP courses at Frontier. I've been at Frontier 15 years and I've not taught in the DMP courses. So it's so exciting to me to hear about the work you all are doing. So it's very heartening. Well, we are just about, I see on my clock, about 1 minute until 8 o'clock Eastern. So I'm going to move toward closing our session. And I want to thank you all so much for spending this time together. I'm so grateful to have had the opportunity to be with you and to learn from you. So thank you, everyone.
Wow. I just want to say, Dr. Cockrum, that was a great, fabulous presentation.
Oh, thank you.
You're welcome. I would like to highlight how important the topic is frontier nursing service and quality improvement. I'd also like to thank our participants for coming and engaging in the discussion. Students, please remember to submit proof of your attendance if it's appropriate for your classes. And yeah, this is really exciting. Thank you everyone for coming.
Thanks, everyone.
Good night.
Dr.
Good
Cockrum.
night.
Everyone have a
Thank
good
you.
night.
Thanks. Bye,
Thank
everyone.
you.
Bye.
Hold on.
Thank you.
Thank you.
Oh my God. Oh,
Thank you.
Everyone.
thank you.